Welcome to today's webinar, Tobacco Cessation Barrier 101, the Impact on Quitting. If you have questions or technical difficulties during today's webinar, please use the chat feature. And if you are missing anything, today's webinar will be recorded. And now I will turn it over to Ann DiGilio. Please go ahead.
Thank you so much, and thank you for joining us today on today's webinar, Tobacco Cessation Barriers 101, the Impact on Quitting. Again, if you have any technical difficulties, please use the Q&A box. We'll answer them as quickly as we can. Additionally, as we go through today's webinar, if you have any questions on anything, please put them in the Q&A box. If we get to the question before the Q&A period, that's great, and if we don't, we'll hopefully be able to have a chance to answer them at the end. And then if we don't have a chance to answer them at the end, both myself and then my colleague, Reggie Kwadwani, our email addresses are at the end, so feel free to email us at the end. And so we hope to have plenty of time to answer those questions. Additionally, we're asking one more thing of you. At the conclusion of this webinar, we're going to send you an email, and it'll have a survey just kind of about how today's webinar went, what future webinar topics might be of interest to you. And so if you could just take, 5 to 10 minutes to fill that out, we'd greatly appreciate that. We really want to make sure that the information we provide is relevant and helpful to you in your work. As was mentioned, my name is Ann DiGilio. I'm the National Director of Lung Health Policy here at the American Lung Association. In my role, I direct the American Lung Association's Tobacco Cessation Policy Project, which includes directing 2 federal grants that we have from CDC. Including collecting data on tobacco cessation coverage in the Medicaid population, as well as providing technical assistance. So as I mentioned, please feel free to contact me. My contact information will be on the last slide. And now it's my pleasure to turn the webinar over to my colleague, Reggie Kwadwani.
Hi, everybody. My name is Reggie. I'm the National Specialist for Cessation Policy here at the American Lung Association. My primary responsibilities are to manage those 2 federal grants that Ann mentioned and directs. So yes, of course, if you have any questions with respect to cessation coverage, feel free to shoot myself or Ann an email, and we'll be happy to help you out with that. And we will get started. Okay, so quick overview, the structure of this presentation. We'll go over some background information, then we'll move on to the structural barriers to cessation treatments, and then other barriers. And then we'll go over some resources, and then we'll have some time at the end for questions. So I first want to talk about the burden of smoking. Smoking is the leading cause of preventable disease and death in the United States. It is responsible for more than 480,000 deaths per year in the United States, and this also includes more than 41,000 deaths resulting from secondhand smoke exposure. More than 16 million Americans are living with the disease caused by smoking. In addition to these health consequences, there are also several economic consequences as a result of smoking. The total economic cost of smoking is more than $300 billion a year. This includes nearly $170 billion in direct medical care for adults and more than $156 billion in lost productivity due to premature death and exposure to secondhand smoke. When looking at smokers' attempts to quit, we find that 68% of adult smokers have reported wanting to quit completely. In 2015, only half of smokers received advice to quit from a health professional and made a quit attempt, and fewer than 1 in 10 smokers quit successfully. In the Medicaid population specifically, only 10% of current smokers received a prescription for cessation medication. So here we can clearly see a disparity between smokers wanting to quit versus how many actually quit. So I want to point out that there are several reasons why people have such a difficult time quitting smoking. Nicotine is a highly addictive chemical. People can also link smoking with many social activities, so they experience chemical and social addictions. There are also several barriers to cessation treatments that make it harder for people to quit, but we'll go more in detail about that later in this presentation. Moving on to comprehensive cessation benefits, the FDA has approved 7 smoking cessation medications, which are considered to be first-line treatments as defined by Treating Tobacco Use and Dependence in the 2008 update. These include 5 nicotine replacement therapies, or NRTs, the gum, patch, lozenge, nasal spray, and inhaler, There are also 2 non-nicotine medications, bupropion and varenicline. In addition to medications, individual, group, and phone counseling have all shown to be highly effective. Using medication or counseling alone can increase someone's chance of successfully quitting, but the combination of both is more effective. Cigarette smoking is down, but almost 38 million American adults still smoke, and there are several disparities in tobacco use that remain across groups defined by race, ethnicity, education level, socioeconomic status, and across regions of the country. For instance, rates are highest among people with a GED certificate at 36.8% and lowest among those with a graduate degree at 4.1%. We also see that smoking rates are higher among people living below the poverty level than those living at or above this level. For a family of 4, living below the poverty level means they would be bringing in less than $25,750 this year. And then also we see adults that have experienced serious psychological distress were more likely to be current smokers than adults that did not report serious psychological distress. And that is about 35.2% versus 13.2%. And now I am going to let my colleague Anne talk about Medicaid.
So as Reggie mentioned, the Medicaid population smokes at a much higher rate than the population with private insurance. So I'm going to give a little bit of a background about the Medicaid program and then talk about some coverage requirements in both Medicaid and in other types of insurance, just so we kind of have some background as we go into talking about the barriers. And so Medicaid, for the very simplest definition of it, is health care coverage for low-income individuals and families. It's funded jointly by the federal government and the state, and it's a percentage-based. So, for example, a state might pay 30% of their total Medicaid expenditures, and then the federal government picks up the additional 70%. The Affordable Care Act gave states the option to expand Medicaid. With the Medicaid expansion, the sharing proportion for that new population, the federal government picked up a much bigger chunk of the tab. So it started out with the federal government picking up 100% of that tab for that expansion population. And it's slowly moving down, so now the federal government picks up 90% of that tab, and the state only has to put in the extra 10. So it's a really good financial deal for states to expand their Medicaid program. Additionally, it gives a lot more people coverage to healthcare services, including tobacco cessation services. Because of some court decisions and kind of how the law was designed, states have had the option to expand Medicaid. Currently, 37 states in the District of Columbia have adopted Medicaid expansion. There is a caveat with that number. While Utah's voters voted to expand the Medicaid program just yesterday, the legislature passed a bill and signed by the Utah governor to roll back that expansion. So it's actually technically only 36 states in the District of Columbia that have expanded. But clearly the country is moving towards Medicaid expansion. Kind of the numbers, when we say these percentages, 138% doesn't really mean anything. So for a family of 3, what 138% is an income less than $2,453 a month. But the standard Medicaid program, so those states that are colored in orange on that map, those can have varying different degrees of eligibility. Some as low as 18% of the federal poverty level. And if you're not great at fast math, 18% of the federal poverty level for a family of 3 is less than $312 a month. Typically, some of these non-expansion states with those really low eligibility are also going to require, have a requirement that it only covers parents. So a lot of people are without any health care coverage at all. So again, just to kind of reiterate why we're talking specifically about the Medicaid population, and the barriers apply to everybody, and we'll get into that in a minute, but the Medicaid population really does have a much higher burden of smoking, and as does the uninsured, than the privately insured population. The Medicaid population smokes at a rate of approximately 24.5%, where the privately insured population only smokes at a rate of about 10.5%. Because there are more smokers in the Medicaid program, the burden of smoking-related illness and costs are higher in the Medicaid program. For example, 11% of Medicaid expenditures are attributable to a smoking-related illness, which is just huge. So now I'm going to talk quickly about some of the policies on what is supposed to be covered, so we kind of just have a baseline before we go into kind of what some of the barriers are to get what, this is what people are supposed to get. So we're going to then talk about kind of where the disconnect is. So first, and I mentioned kind of standard Medicaid versus expansion Medicaid. So standard Medicaid is going to be the population that would have been eligible for Medicaid prior to expansion because of their income levels or whatnot. And then Medicaid expansion is going to be anybody above that income up to 138% of the federal poverty level. So that state that I mentioned that had 18%, so anybody making, if that state were to expand, the expansion population would be anybody making 19% to 138. Again, that's going to vary slightly by state what that expansion population looks like because of other requirements. Sometimes it's going to be all all childless adults under 138. So it really is kind of dependent, and I'm happy to answer some of those questions at the end. So for standard Medicaid, the requirement is if a state participates in the Medicaid drug rebate program, they cover one medication, they're required to cover all of the manufacturer's medications, and then they get steep discounts for doing that. Some may argue if they're steep or not, and we can have that debate some other time. Prior to the Affordable Care Act, there's an exclusion list, and tobacco cessation medications were on the exclusion list. So states did not have to cover tobacco cessation medications in order to get those rebates. The Affordable Care Act removed tobacco cessation from that exclusion list. So states, in theory, should be covering all 7 FDA-approved medications. However, there's nothing in the Affordable Care Act or no other federal regulation that looks at barriers in those state Medicaid programs. So state Medicaid programs and MCOs are still able to impose barriers such as cost sharing or prior authorization and other things that Reggie is going to get into in a few minutes that can really limit a person's ability to quit. Additionally, there were requirements in the Affordable Care Act regarding pregnant women. Pregnant women are required to have a comprehensive benefit, including all 7 FDA-approved medications and all 3 forms of counseling. And this benefit is supposed to be covered without any cost sharing for this population. So that's a really important thing to note. The Medicaid expansion population, again, a new population because of the Affordable Care Act, is supposed to cover preventive services. So that includes tobacco cessation, meaning all 7 FDA-approved medications and all 3 forms of counseling without cost sharing or prior authorization. Again, the caveat to that is that expansion is optional in states, so it will really kind of depend on which state we're at. Now I'm going to talk a little bit about private insurance. So most private insurance is required to cover the same benefit that the Medicaid expansion plan is going to cover. So again, all 7 FDA-approved medications that Reggie mentioned earlier, as well as all 3 forms of counseling without prior authorization or any cost sharing. And this includes most employer-sponsored plans, any plan sold on the exchange, and almost any non-grandfathered plan. However, there are different benefits for other populations and other types of coverage. For example, Medicare has different benefits. Medicare doesn't cover any over-the-counter medications, so you're only going to see the NRT inhaler, NRT nasal spray, and then you're also going to see bupropion and varenicline, as well as counseling coverage. There are other plans like short-term limited duration plans, which have been recently expanded, and those plans are not required to cover any sort of cessation treatment. Additionally, there are grandfather plans that are also not allowed to cover any other cessation. They're not required to cover any cessation treatment. Though grandfather plans are becoming less and less common, we're still kind of analyzing what the impact of the short-term plans are, but we anticipate to see more and more of those in the future. So now I'm going to talk about some structural barriers to accessing cessation treatments. And again, these are in both Medicaid and in private insurance. They're kind of barriers due to how the healthcare system is set up. The United States has a bunch of different microcosms of health systems. So you've got Medicaid, which is its own thing. You've got private insurance. It's regulated by both the federal government and sometimes the state government. and it's funded by multiple sources. So there's a lot of disjointedness within the healthcare system, which creates some barriers to accessing care. And so I'm going to kind of talk about some of those, and then Reggie is going to go through some of the barriers that we've talked about more often, some of the barriers that we collect in our Medicaid cessation coverage data. And so hopefully, if you've got questions, again, please put them in the Q&A box, and hopefully we will get to that. So again, talking about some structural barriers in the Medicaid program, one of the biggest things, especially for structural barriers in general to accessing cessation treatment, excuse me, I misspoke, you know, to get these medications without cost sharing, like most patients are able to do, you need to get a prescription. So you need to be able to go to the doctor to get that. So that can be a barrier in and of itself. Even the medications like the NRT gum, patch, and lozenge, which are also available over the counter. Another structural barrier is that coverage can vary between plans. So a provider might see a Medicaid patient in the state and then see another Medicaid patient, and even though they're both Medicaid patients, they could very easily have different types of coverage. Additionally, privately insured people can have different types of barriers on coverage, or there are plans that are maybe not necessarily implementing the provisions of the Affordable Care Act around cessation coverage the way that we would like them to. So there can be some variation in coverage still in those plans, which makes it very difficult for a provider to be able to write a prescription. I was talking to someone a few days ago and was talking about working with pharmacies to make sure that the appropriate generic brands were stocked of NRT, were stocked in their pharmacies, so when a Medicaid patient came, they could get that prescription, because the plan only covered some generic, the Medicaid program only covered some generic treatments, not all of them. Additionally, another structural barrier that we've seen is the Affordable Care Act. While the Affordable Care Act prohibits discrimination against pre-existing conditions, it does allow plans to charge more for smoking for smokers, and that can be a 50% tobacco surcharge. So if your premium would be $1,000 a month, it could be $1,500 a month if you were up to $1,500 a month if you were a smoker. The opposite side of the same coin is a non-tobacco user discount. So that would mean that everybody's premium started at $1,000, and then non-smokers got to pay only $500 a month. And we see these both in private insurance, in employer-sponsored insurance, on the exchange and off the exchange. And we're also starting to see these in some Medicaid programs as well. This is kind of just a barrier to get your foot in the door to begin with. There's studies that show, especially in the exchange market and the exchange population, it's not that people are quitting because of these programs, but they're actually not even enrolling in insurance. So they don't have the opportunity to get the medications and treatments that we're talking about in a minute. And then lastly, one of a big structural barrier is not having insurance coverage at all. And while health coverage and insurance coverage rates have gone up in recent years, there's still a lot of people that don't have coverage, whether that be because premiums are too high, maybe they've got a plan that doesn't cover cessation treatment, and then the states that haven't expanded Medicaid eligibility, there still definitely is that coverage gap. And then in Medicaid, the thing that I like to think about in Medicaid, obviously in addition to having a higher burden of smoking, a lot of these same issues that I talked about in the last slide are just exacerbated in this population. And additionally, Medicaid has a lot of special things around the edges. So there's a number of different eligibility limits. So again, in some of those non-expansion states, in addition to being very, very poor to be eligible, you also need to have a dependent child. So that could cut out a number of people from even accessing coverage. There is a lot of variation among plans, especially the states that have gone more MCO plans. There are a number of states that limit the number of prescriptions somebody can get a month. So if a person has a number of comorbidities and they're trying to manage maybe their asthma or heart disease or diabetes, they might not have the number of prescriptions a month that allows them to quit smoking. And then there's a number of states that have limits who can provide cessation counseling and who can be reimbursed for that. And I know that's a really, that's a very topical issue. But so if you're going to see your cardiologist because you're having difficult smoking, you're having difficult, with your heart and breathing, or you've had a heart attack and you're trying to recover from that, you might not be able to get a treatment or a prescription for a cessation treatment, which could also help the underlying heart condition. So states have a lot of flexibility in their Medicaid programs, which can be really good or can be not so good. So, it's really important to kind of keep some of those things in mind when we're working with the Medicaid population. Now I'm going to turn it over to Reggie. She's going to talk a little bit more about some of the barriers that we talk about, specifically in the data collection that we do and just in general. So, Reggie.
Okay, so the first one I'd like to talk about are out-of-pocket costs. This includes co-payments, co-insurance, and deductibles. A deductible is the amount you pay for covered health care services before your insurance plan starts to pay. After you pay your deductible, you're usually asked to pay either a co-payment or co-insurance for covered services, and a co-payment is the amount of money the patient is responsible for paying at the pharmacy, the doctor's office, or other healthcare sites before they receive treatment. And then your co-insurance is the percentage of costs of a covered healthcare service that you pay after you've paid your deductible. So the impact of this, high out-of-pocket costs can deter tobacco users from quitting. Individuals, including Medicaid enrollees, might be less likely to use tobacco cessation treatment with high out-of-pocket expenses, particularly for those cessation medications. We at the Lung Association, Ann and I look at co-payments specifically within state Medicaid programs, and so far as it stands, 10 state Medicaid programs have co-payments, and 12 states and DC's Medicaid program, the presence of co-payments varies by plan. The next one I'd like to talk about are prior authorizations. So this is when plans require that either the member or clinician contact the insurance program, Medicaid plan, or managed care plan for authorization of a medication or treatment. Plans tend to do this to steer patients towards less expensive medications, and we tend to see prior authorization requirements mostly with respect to the nasal spray or inhaler. The impact, the prior authorizations can delay treatment or cause the patient to get discouraged and stop seeking treatment. There was a study that showed individuals that needed prior authorization to access tobacco cessation medication had 80% lower odds of receiving treatment compared to individuals enrolled in programs with no restrictions. So this is a significant barrier to accessing tobacco cessation. 18 state Medicaid programs require prior authorizations, and then 17 states and DC's Medicaid programs. It varies by plan. Stepped care therapy is a type of prior authorization. Essentially, what this does is require patients to try certain medications before they're allowed to try others, which is interesting in the case of tobacco cessation because all of the 7 treatment options are considered to be first-line treatments. Usually the first step in this system is the gum, patch, or bupropion. They're generally the cheaper options. And only if the patient fails using those methods are they allowed to then try other medications. And this is also really interesting because your provider could decide a certain treatment option would be the best for you, but you'd still have to use something else and fail and then be able to get what your provider recommended in the first place. So it usually discourages the use of those more expensive medications, and this really, step care therapy fails to recognize that patients may have tried some treatments before in other quit attempts and would only want to try treatments they hadn't tried before. So essentially, each quit attempt, they're forced to start at square one. As it stands, 11 state Medicaid programs do require stepped care therapy, and then 10 states, it does vary by plan. So counseling requirements. Some insurance plans and Medicaid plans require enrollees to receive counseling in order to get cessation medication to try and deliver a more comprehensive intervention. So this has become, unfortunately, an unintended consequence of being a barrier to accessing medication, cessation medication. The U.S. Public Health Service recommends that while health plans should encourage a combination of counseling and medications, they shouldn't require it because this requirement could discourage certain smokers, so those wary of or unable to attend counseling, from attempting to quit at all. So, for instance, with people with lower socioeconomic status, they're really impacted by this behavior because you have to think about the cost of transportation to these counseling sessions, cost of childcare if they have children, or if they're doing phone counseling, cell phone minutes. That all really adds up. So it's unfortunately an unintended consequence. As it stands, 9 state Medicaid programs have counseling requirements, and 6 state Medicaid programs, the requirements vary by plan. Coverage limitations. So annual limits, as we know, quitting smoking permanently often requires multiple quit attempts. And annual limits, this is when coverage for quit attempts are limited per year. So for example, state Medicaid expansion programs and most private insurance plans have to cover a minimum of 2 quit attempts per year. Some don't cover anything beyond this, but they do have the option to provide additional coverage. Duration limits, this is in reference to the number of days plans are required to cover cessation medications and counseling per quit attempt. State Medicaid expansion programs and most private insurance plans have to cover a minimum of 90 days of cessation medication and 4 cessation counseling visits per quit attempt for their expansion quit attempts. Public Health Service guidelines found that some individuals may require more than 90 days of medication or more than 4 counseling sessions to successfully quit smoking. After an individual reaches the limit on medication or counseling, they may be denied services or required to pay out-of-pocket costs for the remaining treatment. We also have dollar limits. The cost of treatment depends on a variety of factors, including what type of medication and or counseling a patient is using and the length of their treatment. Limits on the dollar amount plans will spend on an individual enrollee could prevent them from receiving the full course of treatment based on their individual needs for quitting successfully. We tend to see this mostly in private insurance, where people get $400 to $500 per quit attempt per year, and that money could either be used for counseling or medication. It really depends on the plan. Last but not least, there's also lifetime limits, and this is when coverage for quit attempts are limited to a certain number over your entire lifetime. So what these limits, all of them, fail to recognize is that tobacco use is an addiction that can be fought for years and that relapses are likely for most users. Most smokers try to quit many times before they're successful. The average is 7 to 10 times, and if someone is limited to, let's say, 2 quit attempts per year, then it could take someone maybe 5 years to successfully quit smoking. Limiting the number of quit attempts per year is a big barrier, and really this can disincentivize someone from trying to quit or try to quit without using evidence-based treatment plans or medications. So as it stands, 25 state Medicaid programs have annual limits. 11 states and DC's Medicaid programs, those limits vary by plan. 26 state Medicaid programs have duration limits, with 17 states and DC's Medicaid programs, those limits varying by plan. And then there are 2 Medicaid programs, state Medicaid programs, where lifetime limits vary by plan. So the next thing I'd like to talk about is limited promotion of coverage. So there are several states where there is limited or a lack of adequate promotion of cessation treatment coverage that enrollees have available to them. Most tobacco users want to quit, but need that motivation and information to succeed. Increasing awareness of benefits to smokers, to providers, family members, loved ones can lead to critical increase in cessation uptake by smokers. Overall, based on those barriers that I just talked about, I do want to point out that 47 states and DC's Medicaid programs impose 1 or more barriers to tobacco cessation services. There are 2 state Medicaid programs, Kentucky and Missouri, that impose no barriers to tobacco cessation services. So we know that this is completely doable. So next, we're just going to talk about resources, and Anne is going to take over that.
Great. So now we've talked a lot about ways that make it more difficult for people to quit. So now we're going to hopefully talk about some resources and some provide some examples of ways that we can overcome those barriers. And I think some of the first one, and I think probably one of the most important one, that is just awareness of what exists. So first of all, I think that listening and learning more about what barriers exist is a great way to figure out what they are, because sometimes while there are some states, at least for the state Medicaid program, that's removed them, sometimes that's not possible. So really that education and understanding and making sure providers know what's covered is really an important step as well. So kind of going over some strategies to overcome barriers. The first, the one that I like the best, is to improve coverage. A number of states have recently done that. South Carolina, Kentucky, and Missouri have all improved coverage and have either completely removed their barriers or greatly limited their barriers. Again, and those are some of those barriers that Reggie talked about. Some of those bigger, more overarching structural barriers still exist. However, I will say all three of these states have a comprehensive benefit, so even within their managed care plans. So a provider will always know what's covered. South Carolina and Missouri both did theirs through more administrative action. Kentucky passed a state law to do that. And Kentucky's law is much broader than just the Medicaid program. It's actually most privately insured plans in that state, with some caveats. And if you're really interested in Kentucky, please feel free to email me at the end, and I can give you more information, but we don't need to go down that rabbit hole right now. So that's one way you can do it. We also have a case study on how South Carolina has improved their coverage on our website, and I believe it's on the last slide as well. So if you want to kind of understand a little bit more about how they did it, you can kind of, that's one example. Sometimes there just isn't the will within the state to be able to improve coverage, or, there are still going to be, plans that are not regulated at the state level, so sometimes that's not an option. Another way to get around, improving coverage is to incentivize providers to help smokers quit, either through quality measures, either at the federal level, at the state level, or even at the plan level. So there's a lot of ways to help to incentivize providers to make sure that they help their patients quit. And then the last thing I think that's really important is, again, to inform everybody about what the benefit is. And I think a number of states did this. Michigan's done this. Kentucky did this as a precursor to their state legislation, is to kind of figure out what is covered and publicize that. So it's not easy to do at all, but it's much easier to do for the Medicaid program than for private insurance. But if providers know what's covered, if patients know what their benefit is, what their coverage benefit is, they can go to their provider and say, hey, here's my formulary, this is what's covered, these are the steps I have to go through. So they don't get to the pharmacy where the pharmacist says this isn't covered, you have to pay X number of dollars, or I can't give you this prescription, or whatever that interaction would be. So if we can't make coverage perfect, we can figure out ways around that, and that's also really important. The other thing that's really important is promotion, and Reggie mentioned this too. And that kind of falls under that last thing that I mentioned about really needing to improve, not necessarily if you can't improve coverage, and even if you can, make sure people know what they should be getting. Providers know that they have the ability to bill for counseling, and they'll get reimbursed, that they have the ability to say, to write a prescription and know that it'll get filled, and know that it's not going to get kicked back because of a prior authorization or because of a stepped care therapy requirement. We also know that, especially among the Medicaid population, utilization is really low. Less than 10% of Medicaid enrollees that smoke received a prescription to quit. So again, really, really low. And again, as I mentioned, the smoking rate for both the Medicaid population and the uninsured is, very similar at 25.4 and 24.5 and 24.7%. So it's really important that people understand that there is help to quit. One resource that we have that I'd like to draw your attention to, we've got a promising practices and lessons learned document around promoting tobacco cessation benefits. We worked with, a handful of states that have improved their efforts to promote tobacco cessation benefits. And on this slide, I've listed kind of the four main takeaways these number of states, and kind of after doing this, we've kind of pulled together. And the first is, and this was specific to Medicaid, but I think it's very applicable beyond Medicaid too. But to kind of understand what the coverage landscape is first. If you're promoting in Medicaid, Medicaid then. If you're promoting in private insurance, however best you can do that. So understand what's covered and kind of when I say covered, but also understand what the barriers are. If a person's going to need a prior authorization for a treatment, it's better that both the provider and the patient know about it so they can act on it before the patient leaves the provider's office. So that prescription is set when they go to the pharmacy to pick that up. So figure out what that is. Then it's really important to build relationships with either the Medicaid office or the private insurance companies that you're working with. As Reggie said at the beginning, smoking is the leading cause of preventable death and disease. So it's good for everybody for people to quit smoking. So to really kind of build that relationship and make sure you have an ally and a partner. And then kind of continuing on that, if you can partner at a higher level and if leadership cares about it, will make you more effective. So that's really important. And then lastly, develop a plan for evaluation. It's really important to have data to know that what you did worked. So you can share it with other states or other insurance companies if you're working with private insurance. And so you don't just keep doing the same thing if it doesn't work. Another resource we have that I'd like to draw your attention to is our billing guide for tobacco cessation screening and cessation treatment. Billing is a big barrier in and of itself. As I mentioned earlier, there are some states that don't allow every type of physician to be reimbursed for cessation counseling. The counseling reimbursement can vary based on what provider you are, what type of insurance or Medicaid program you have, what type of CPT code and what type, which they're both diagnostic and treatment codes. So what those codes are, if you don't use the right combination, you can get denied coverage. So there's a lot of information, and unfortunately, unless you look at each plan individually and each patient individually, you're not going to be able to find the answer to it. So we've created this guide, and it doesn't have all the answers, but it gives you a list of questions to help educate providers and educate people in general on how to bill and what questions you need to ask to make sure you're using those right ICD-10 codes, which are those diagnostic codes, and then the CPT codes, which are those procedure codes. If you're using figure out which ones you need to use to get the right combination so you do get paid if you're a provider or if you're working with health systems. So that is what the billing guide is. We hope it can be helpful, and we know that it probably creates more questions than it answers, but I think it creates the right questions and the questions that we can, to help to get to a better outcome. And then lastly, I want to share, we've got a number of resources on lung.org/cessation-TA. We've got a resource library. We've recorded all of the webinars we've done, and this one will be posted once it's done as well. And so if you want to watch it again, if you want to, refer a colleague to watch it, maybe missed it, so that exists there. We also have a number of toolkits to work with different, so we can work with different partners, either hospitals and health systems with our community benefit toolkit, or to work with enrollment assisters with our assisters toolkit. And then in the next slide, we're hoping to have got a bunch of time for questions, which we're really excited about. And Reggie and I are always happy to answer anybody's specific question to the best we can. So you can either email our generic email address, cessation-TA@lung.org, or if you wait until right out now, you will now see our actual email addresses, and we will keep this slide up as we answer questions. So please feel free to write down our email addresses and or our phone numbers so you can give us a call or send us an email later if you've got questions. And I'm going to work through some of the questions now, but just a reminder, if you can please fill out your survey when you get that post-webinar email. We, again, really do want to make sure any information that we're doing, either be webinars or anything else, is relevant and helpful to you as in your work. So let's look at some of the questions. And there's a lot, so thank you so much for doing questions. And so it's going to take me a second. So the first question I got, does the federal government continue to pay 90% of the tab for Medicaid expansion over time? The answer to that question is yes. Currently, as the law is written, the federal government will continue to pay 90% of the expenditure for the Medicaid expansion population in perpetuity. Okay, so this question, and if I get your question slightly wrong, feel free to type in and re-ask it. So the next question, is it common for a state's Medicaid program to cover all 7 FDA-approved medications and counseling, but that the MCOs may have limits, such as the type of medication they cover? So yes, that I think would be common. So a state, let's take South Carolina as an example that has that overarching policy that all 7 FDA-approved medications must be covered. They are not brand specific in which medications are covered. So there still could be some confusion among providers. So that's, why that provider education and promotion is so important, even if you've already have that comprehensive benefit. So there can still be different, in some states are not as prescriptive. So you could still have a state where all the medications are required to be covered, but then the barriers could, the barriers or some of those limitations. So sometimes one plan might have a prior authorization and another doesn't, or one might have a stepped therapy and another doesn't. So it really can vary by plan. Okay, so somebody has a good question. Is there a good resource for finding out the Medicaid rules in my state? So there's a couple of resources that you can do. So the first resource I would say, and I'm going to promote myself first, is we've got the Lung Association collects Medicaid coverage data. So for example, for some of those states where they have that comprehensive benefit and they've got that state law or whatnot, that will be cited as the source. So that's an easy way to start there. And then if you've got more questions, I think a good place to start kind of is seeing what laws are on the books, what the Medicaid program covers. Feel free to contact your local lung association, or Reggie and I are happy to kind of help you figure out where to start and dig in. Some of it is easy, some of it's not. Some states do have a comprehensive or a coverage requirement, not all states do. But I would start on our website with the cessation data, the coverage database, and then we're happy to try to help you kind of figure out where the coverage requirements are after that. Okay, incentivizing providers. Can you provide some examples? I'm happy to do that. So I think the best way I think of as incentivizing providers is using quality measures. So one way to do that is through like a capitated payment model. And a provider would sign up, providers or a group of medical practice would sign up for this in advance, where the payment is actually slightly less. Maybe the provider gets 50% or 90%. I don't know the exact structure, so please don't quote me on that, of the total payment upfront. And then if they do well, they can earn back the additional 10 or 50 or whatever that missing chunk is. And if they do even better, they can earn more money on top of that. So one thing you can say is, a lot of this is through like the electronic health records of some of those reporting systems. Has a provider asked a patient if they smoke? They asked a patient if they've tried to quit? Have they prescribed cessation medication? So there are some ways you can do it to really try to incentivize providers to do it through the quality measures method. Another way I know some health systems have done it, and they've incentivized providers kind of more through some of their internal metrics. For example, patients that are diabetic and maybe have everything under all their, they'd be a completely under controlled diabetic. Their A1C is under 7, their blood pressure is where it should be. Everything else is good except they smoke. So then they've kind of targeted those patients and kind of internally done like a ranking of this provider's doing the best with their patients to get them to where they need to be. So those are a couple of different ways to incentivize patients, or to incentivize providers, excuse me. Okay, so somebody asked about where they can find the billing guide, or maybe it was the promising practices. They're both on our website, but I can send them, we can send them up through the web, after the webinar. We can include links to those. But if you go to that lung.org/cessation/TA, you should be able to find them there. If you've got questions, again, please feel free to email myself or Reggie, and we can help you with that. Okay, so this is a good question, and I think timely. In terms of cessation, is there anything for adolescents or people under the age of 18? So currently the FDA hasn't approved any cessation medications for people under the age of 18. The caveat but that's only the medications. There are, counseling does work for, and can work for patients under the age of 18. There's more research being done every day to try to help younger people quit using tobacco products. So it's not the greatest answer, but there is counseling available for people. There are a number of programs, including the Lung Association has one, but there are many of those that exist. Okay, so this is a good question, a little bit long, but since the majority of tobacco treatment is not delivered through physicians in the United States, how can we, advocates of state Medicaid programs do to view certified tobacco treatment providers as recognized treatment professionals who can deliver care and get reimbursed? They are the workforce that is most likely to deliver the actual treatment. So this is going to, again, be one of those things that is going to be a state-by-state, in terms of the Medicaid program, it's going to be a state-by-state issue. It could even be a managed care plan by managed care plan issue of which providers both are licensed to provide treatment, and then which providers, and when I speak of providers, I talk kind of the whole gamut of providers. Both are licensed to provide treatment as well as are able to be reimbursed. The Affordable Care Act does have a provision to allow non-licensed providers to be able to reimburse for treatment. A state would have to submit a state plan amendment in order to do that. They'd have to identify which types of providers they would be, which billing codes they would use, and at which levels they would be able to get treatment, but that is a doable thing, although it can be a little bit complicated and a little bit, state plan amendments are a big process. One thing that might be helpful is to partner with other types of disease states. So for example, asthma educators could also be something, and do it kind of as a whole public health effort together. Might make it a little bit easier, but it is something that can be done. Also, when you talk about, being the most economical in providing cessation treatment, if everybody practices to the top of their degree or the top of their certificate, we can make sure that everybody gets the best treatment possible. Okay, this is a really easy question. Can you show the web address for the additional resources and information? So here is that one. Okay, what is the difference between Medicaid and Medicare coverage for NRT? What are the future projections for Medicare coverage? So Medicaid, which is for the low-income population, for the standard population is required to cover all the medications through that drug rebate program that I spoke about earlier. The Medicaid expansion program is supposed to cover all the medications and the counseling. And then for Medicare, which is care for the 65 plus population in the United States, they only cover prescription drugs, so no over-the-counter drugs. The NRT gum, patch, and lozenge are all over-the-counter medications, so those are typically excluded from coverage. And I don't anticipate that changing anytime soon, but that's about it. Okay, so a couple of people asked about fact sheets. We have a number of fact sheets available. So if you're interested in a specific fact sheet about what different types of plans are required to cover, we have fact sheets about what Medicaid covers, standard Medicaid covers, Medicaid expansion covers, most private insurance, short-term limited duration plans, VA, TRICARE, and Medicare. So we've got a whole host of those, kind of just a basic, this is what the program is, and then this is what the coverage requirements are. And they're all in that resource library at lung.org/cessationTA. And again, if you're having trouble finding it, you can email that cessationTA@lung.org or Reggie or I to get that information. I am not familiar, so this person asks about, are there tobacco cessation programs specific to smokeless tobacco users or electronic cigarette users? I am not familiar with any specific programs for those, for those types of tobacco products. We would encourage them to use, kind of what the evidence-based treatment is for all tobacco products. And to talk with your provider kind of about what the best thing is for you and the specific addiction that that individual has. Okay. So regarding the incentive questions, so what might somebody include in a quit pack? So I think that is, kind of when you call the helpline, you get the NRT, and so that could potentially be an incentive for an individual to quit. I think it's really also important to maybe potentially provide some information to connect them back to their provider and connect them back to, the medications that are covered through their insurance plan or Medicaid plan if they have that. So do you have any ideas for incentives for people attempting to quit? The only thing I can think of is a gift card to cover co-payments, but maybe any others, maybe more fun ideas. So there is a study out of California, and they tested different incentives through their quit line of what would motivate patients to quit. And they did small, I think it was Visa gift cards and different monetary amounts. And so I've seen that type of thing be done before, but I think gas cards was another one at one point. So there are a couple of studies that look at kind of what incentives have worked. And so there was recently data released kind of about that study out in California and kind of how they did it and worked with, again, more low-income patients and Medicaid patients. So that might be a good place to look. And if you've got further follow-up questions, please feel free to reach out. Okay. So are there specific behavioral health billing codes to be aware of when providing tobacco cessation treatments to patients at a substance abuse facility? I don't believe there are specific billing codes. I think you'd use the same ones. Occasionally, you'd want to use an extender billing code, and all of that information is in detail in the billing guide. And if you've got additional questions, we're happy to follow up. But I would assume you'd use the same main billing codes, the same diagnostic code, and the same procedure code, and then you would put a different extender on there. So to say, this is part of, a behavioral health stay. Somebody asked a link to the California study. Again, if you email me, I can find it. I don't have that off the top of my head. Okay, and I think that is most of our questions. And so I think we've got, we're right at about the hour now. So I want to just thank everybody for joining. Again, if we didn't get to your question, I'm sorry. But please, again, feel free to email us and follow up. We are happy to, respond as you email us, and would like to try to be a good resource. And again, if I could please encourage you to take the follow-up survey that you'll get in the email afterwards, and we'll also include those links to both the billing guide and then the promotion document. So thank you very much. And Kayla, can I turn it back over to you?
This does conclude today's program. Thank you for your participation. You may disconnect at any time.